morning. Good morning. So today this will be the last algorithm that we are going to discuss in the ACLS. Okay. So we have completed all major algorithms BLS. To start with, we started with chain of survival. Then we went ahead with BLS algorithm, cardiac arrest algorithm, tachycardia, bradycardia algorithm, post cardiac arrest algorithm. So these are the algorithms that we have completed now. Now this is the last one. We have got some special scenarios. I'm not going to discuss opioid toxicity algorithm because that is not very common here. So that is the reason why I'm not going to confuse you with those algorithms. So, but this algorithm, cardiac arrest in pregnancy, which is very, very important, and there are certain key concepts that you need to remember. Okay, there are certain things that you need to understand. Terminologies like perimortem cesarean section. When somebody is telling that perimortem cesarean section, what is perimortem cesarean sections? What is lateral displacement of uterus? There are certain terminologies that you need to remember. And in a pregnant patient who is having cardiac arrest, we need to think certain other factors also why this patient is having a cardiac arrest. So here in a pregnancy, we have to save two life. One is that of the mother and one is that of the child. So when you resuscitate the mother, the child will also be all right. So that is a basic concept that you need to remember. So there is certain changes in the algorithm part wise, it's the same. There is no major differences. You have to go for the causes for cardiac arrest, look for the causes, but there are certain points that you need to remember. So additional points that you need to remember here. Okay, so first you have a patient who has got, I'm not going to an unresponsive victim, all those factors I'm not going to discuss. So straight away we have a patient who is a pregnant lady who has a cardiac arrest. Okay, so you know that in pregnancy we have divided them into trimesters. So trimesters means first trimester, second trimester and third trimester. So as the trimester increases, the baby growth increases. That's what it is called, because depending upon the time frame of the pregnancy, usually up to 40 weeks you can have a pregnancy. So 40 weeks is totally divided into three trimesters. First 8 weeks, 8 to 28 weeks, then 28 to further weeks. So three trimesters they have divided, and in those trimesters what you have to understand is that in the first trimester, in the first part of the pregnancy, they coming in cardiac arrest because the baby is very, very small. So the uterus will not have distended to that extent. But as the trimester increases, as the baby size increases, the uterus start get distending. So what will happen? The uterus will be displacing your major abdominal organs, right? It will be displacing to sideways, and uterus will be the major part of your abdominal cavity. So what will happen? This uterus will go and start compressing your major structure is inferior vena cava. So inferior vena cava is one structure where you have having venous return. So the blood has to come from the lower extremities via inferior vena cava to the heart. So what is happening? This when the patient is lying down flat like this gravity uterus. So suppose you imagine that this is the patient that is lying down. There is a gravity uterus. Okay. So this gravity uterus is going to compress the inferior vena cava. So that inferior vena cava is getting compressed. So as a result, what is happening? There is no venous return. So as a result, there is no venous return and there is hypotension. So as the trimester increases, the size of the fetus also will increase. So the uterus size also will increase, resulting in more problems. So one important concept that you need to remember is that whenever you have a pregnant lady, when the patient is lying flat, when you are checking the blood pressure, it will not be correct. So whenever you want to check a blood pressure, you have to displace the uterus to lateral side. So laterally you have to displace the uterus, or you can give a small pillow to the patient and you can ask them to turn little bit to the one side. Mostly they will be comfortable turning it to the left side, so that the pressure over the vena cava can be released and so the venous return improves. So whenever you see a hypotension in pregnant lady, you should not jump and say, oh, this patient is in hypotension. This uterus lateral uterine displacement has to be done. So that is one concept that you need to remember. So you have a patient who has a cardiac arrest. You have to continue with high quality CPR. There is no doubt. Continue your high quality of CPR. There is no change in position of giving the CPR. We will have doubt whether the position need to be changed or not. No, the position is the same, that you need to continue the compression Defibrillation when indicated, as we have already discussed, when you want to defibrillate, whenever you see a shock of rhythm, you need to defibrillate, and you have to go ahead with other ACLS interventions like drugs like epinephrine, amiodarone, all depending upon the requirement. So this part there is no change. So just you need to continue. But the important thing is that whenever you have an term patient, so suppose they have completed term, that means they are nearing their delivery, something like 34 to 36 weeks. The patient is coming to you, 34 to 36 weeks, the patient is coming to you, and at that time, the patient had got a cardiac arrest. So you have to remember that it is not an individually as a single person you will not be handled. You need to have a multidisciplinary team that is getting involved. You have to resuscitate the baby also. You have to take care of the mother also. Pregnant related issues are there. So it should be a multidisciplinary team, and you should have an assemble a maternal cardiac arrest team should be available, which comprises of basically an obstetrician. Obstetrician means who is taking care of the delivery. Gynecologist, we can say obstetrician. Then we should have a neonatal specialist. So neonatologist or a pediatric specialist, and we should have an emergency specialist taking care of the resuscitation, and anesthesiologist, very important, because sometimes airway difficulties can be there. So we need to have an expert who can take care of the airway, and maybe an intensive care person also. So these are the additional team members that we might require depending upon the situation. So you have to make sure that these team members are available whenever you have a maternal cardiac arrest, a term baby that you are going to, term mother that is having a cardiac arrest. You have to remember that, okay, this patient this mother is going to have a cardiac arrest. So maybe we need to have immediately CPR. You have started the CPR, and we need to get the help of these people also. So these people should be made available. So that is very important. So that is what consider. Now what is assembled maternal cardiac arrest team? Then you have to consider why this patient has got an etiology of cardiac arrest. Why this lady is having a cardiac arrest? Routine 5H and 5Ts we know. Routine things we know. But there are certain other issues that is there for this lady because she is pregnant. So there are certain other risk factors that we need to think in mind. So major thing is that perform airway management, because airway, as you know, respiratory reserve will be very low in this pregnant ladies because already the diaphragm is pushed upwards. So the respiratory reserve is very low. So compromise, they will suddenly deteriorate. So airway and breathing, they will have significant issues. So airway and breathing management. Administer oxygen if needed. You have to start oxygen and keep saturation above 95%, ideally above 95%. And one more thing is that we have placing an IV cannula, you have to place it above the diaphragm. Why? Because when you are placing below the diaphragm, again the drug delivery might not happen because the vena cava pressure, the drug might not reach. So whenever you are planning, you keep an IV cannula above the diaphragm. So put it in your upper limb. So that will be an ideal thing. So that is one additional thing. And in pregnancy, there is a condition called as eclampsia. I think we have already discussed in last time. Eclampsia. Eclampsia of pregnancy means seizure. The patient can have due to hypertension and seizure they can have. So the drug that we give is magnesium sulfate. So drug that we use there is magnesium sulfate. Magnesium sulfate we will use it for torsade as well as for eclampsia in pregnancy. So what will happen when you give magnesium sulfate? They can go for magnesium toxicity. So magnesium, suppose this patient is already having a high blood pressure and she is receiving magnesium and she has gone into a cardiac arrest. You have to think that whether it is due to magnesium toxicity. If it is due to magnesium toxicity, you have to stop that, and the antidote for that is calcium gluconate. You have to administer calcium gluconate. Just like in our hyperkalemia, you have to administer calcium gluconate. Okay. So you have to remember that whenever a patient is having magnesium sulfate and the lady is going for a cardiac arrest, it can be due to magnesium toxicity. And when you are suspecting a magnesium toxicity, what you have to do? You have to stop giving magnesium sulfate and you have to administer what? Calcium gluconate. So that is what you need to remember. So that is the additional thing. Then there are certain, these are general interventions that we do for all patients, right? We will administering oxygen, continuing ventilation, putting an IV line, but there are certain changes what you need to do in a maternal cardiac arrest. The next important thing is that perform some obstetric interventions. What are those obstetric interventions that you need to do? Most important one that I told, provide continuous lateral uterine displacement. What is that? Continuous lateral uterus displacement. So you have to displace the uterus laterally so that the pressure over the vena cava is released. So that is very, very important. And sometimes what will happen, no, you will be having some, I don't know whether you have gone to the labor room, there will be something called as CTG apparatus. There will be some fetal monitoring devices attached to the abdomen. All those things we need to remove. So fetal monitoring devices, if anything is attached, that needed to be removed because we wanted that area maybe for an emergency cesarean section. So what has happened? Maternal cardiac arrest has happened. So we are just continuing with our routine ACLS protocol, and we are assuming that if the patient was on magnesium sulfate, whether it is due to toxicity, we have to stop magnesium sulfate and you have to give calcium gluconate. And next important thing what you need to remember is that lateral uterine displacement. Very, very important, because hypotension can be because already the blood pressure can be on a lower side, we don't know, and on top of that this venous return is also impaired. So there is no venous return that is going to happen. So we have to do lateral uterine displacement and detached fetal monitors. And as I told, there is a terminology called as perimortem cesarean section. Perimortem. You know about cesarean, right? Because cesarean section is basically lower segment cesarean section. What we are going to do, we are making an incision over the lower abdominal part and we are incising the uterus and we are taking the baby out. That is a normal cesarean section. What is perimortem cesarean section? It all says that when the mother is having a cardiac arrest, if you are trying to salvage that baby, suppose the baby is a term baby, you want to salvage the baby, or maybe after 28 weeks that you want to salvage the child, you cannot wait for a normal delivery. That is not going to happen because she is already in a cardiac arrest. Whether you can salvage the baby, and by doing and taking out the baby, the mother's physiological parameters can improve. So there is a high chance that the mother also can survive. So rather than salvaging the baby, there is a high chance that the mother also can survive by removing the baby. So what we do when we have a cardiac arrest, in a maternal cardiac arrest, pregnancy related cardiac arrest, we can do in the ER itself a perimortem cesarean section. Rather than doing in the theatre, when we are doing along with the cardiac arrest, we will call it as perimortem cesarean section. You understood? So what is perimortem cesarean delivery? If you are doing a perimortem on bedside cesarean when the patient is having a cardiac arrest, so that is basically a perimortem cardiac arrest. So when will you do perimortem cesarean section? Perform perimortem cesarean delivery in 5 minutes, depending upon the provider resource and skill sets. Ideally, the mother had a cardiac arrest. Within 5 minutes of that time, you can try to rescue the baby, and also the mother also will be rescued. You are doing cesarean delivery not to rescue the child alone. We are trying to save the mother, because when the baby is out, the physiological parameters of the mothers also can improve. So that is called as perimortem cesarean section. So that is one additional thing that you need to remember. So perform perimortem cesarean delivery. You have started CPR. Within 5 minutes, the mother have not attained return of spontaneous circulation. Okay, 5 minutes over. We cannot wait anymore. Go ahead with perimortem cesarean section. So that is what it has said. Consider, if no ROC in 5 minutes, consider immediate perimortem cesarean delivery and neonatal term to receive the neonate. So they need to take care of the neonatal algorithm. So that neonatal algorithm we will discuss after pediatric advanced life support. So after this, we will go to the pediatric advanced life support algorithms, and at that time I will say what are the neonatal resuscitation that you need to do. So what we have done, we have a mother who had a cardiac arrest. You have started the CPR, the routine causes of cardiac arrest, 5H and 5Ts we have gone with, epinephrine, amiodarone, whichever is required. If needed, we have gone ahead with defibrillation. Then we have considered that airway issues. Then specific issue, we have put an IV line above the diaphragm, magnesium sulfate stop if the patient is on, add on calcium gluconate, lateral uterine displacement, discharge the fetal monitors, and prepare for perimortem cesarean section. If there is no return of spontaneous circulation after 5 minutes, okay, you have to consider that this baby should be evacuated by doing a perimortem cesarean section. So meanwhile, you continue high quality CPR and defibrillation whenever is indicated, and other ACLS intervention, whatever we have discussed, we need to continue that. Then there are certain other causes that you need to remember. The routine 5H and 5Ts is there, but there are certain other things that you need to consider when it is a maternal cardiac arrest, even it's a pregnancy related cardiac arrest. So This is the algorithm that we have sent. So maternal cardiac arrest, team planning we have already discussed, which all team members is needed. Then priority of pregnant woman in cardiac arrest should include providing high quality CPR. That is the priority for all the patients, not for pregnant patients alone. Everybody should give a high quality CPR, but most importantly, you have to have a lateral uterine displacement. That is very, very important. And perimortem cesarean section. So that is the next thing that you have to remember here. Then advanced airway management. See, airway management in pregnancy can be challenging because the problem is that majority of the time they will be obese because there will be weight gain due to pregnancy. So the doing laryngoscopy itself might be difficult. To visualize the vocal cord might be difficult. So you might need an expert help during that time. So advanced airway can be challenging, but you should not take any chances in pregnancy. The most experienced person should be handling the airway. Suppose there is a person who has done 100 intubation and suppose there is a patient who has done 10 intubation. Those who have done 100 intubation only should be handling this patient. So that should be the priority here. Then the next thing, provide endotracheal or intubation or supraglottic airway, whatever we have discussed. 1:6, 1 breath every 6 seconds is what we need to deliver, 10 breaths per minute, and ETCO2, everything holds good. But lower down you can just see the box here. There are certain A, B, C, D, E, F, G, H that you need to remember here. Certain other A, B, C, D, F, H. So these are the potential etiology, causes of maternal cardiac arrest. So causes of maternal cardiac arrest. So you need to remember this. So general cardiac arrest is there. I am not denying 5H and 5Ts is there. On top of that, if a patient who is pregnant, who is having a cardiac arrest, you need to consider these things also. 1A, it can be an anesthesia related complication. So anesthesia, either the drug or whatever you have given, it can be an anesthesia related complication. Suppose this patient was planned for a cesarean section. Already anesthesia has been given to this patient, suddenly collapsed. So it can be a complication due to the anesthetic agent that has been given. So A is for anesthesia related complication. B is for bleeding, because already there is hypovolemia in our 5H and 5Ts, but in pregnancy bleeding is a very, very important thing, because bleeding can cause significant hypotension and the patient can go into a cardiac arrest. So bleeding is again very important. So that's why they have kept separately bleeding as one of the potential risk factors. Then you can have cardiovascular issues, CVS related. What can have? They can have suddenly stress cardiomyopathy. Suddenly the pregnancy, these ladies can have stress cardiomyopathy. They are more prone to develop pulmonary embolism. So these are the other cardiovascular risk factors that you need to consider. Then you have drugs. Drugs, most importantly, what you have said, magnesium sulfate. They can go for magnesium sulfate toxicity if there is evidence of eclampsia. So these drugs that you need to remember, whether it is due to attributing to any of these drugs that has caused. And next is embolism. Already have said pulmonary embolism. And another embolism that can happen in pregnancy is amniotic fluid embolism. There is amniotic fluid. So this amniotic fluid can get embolized and it can go to the patient, and just like pulmonary embolism, the patient can have symptoms. So that is embolism that you need to consider. And F is fever related. So they have any other sepsis or any other puerperal sepsis. Pregnancy, there can have some sepsis due to them. Due to fever, they can have sepsis and cardiac arrest. So that is another cause that you need to remember. And the general causes like the 5H and 5Ts. The common 5H and 5Ts also holds good here. And finally, hypertension. So hypertension itself can cause into cardiac arrest. So these are the A, B, C, D, E, F, G, H additional potential risk factors that you need to consider for a pregnancy related cardiac arrest. Pregnancy patient having cardiac arrest, these are the factors that you need to remember. See, in routine different from the routine cardiac arrest, drugs, everything is the same, but you have to have certain considerations here. What are the certain considerations that you need to do? First thing, there can be challenge into the airway. Already there is a low respiratory reserve. So that is as A, B. C, in circulation, there can be hemorrhage and bleeding. So they can have hypertension as well as hypotension, because pregnancy related hypertension like eclampsia they can have, and the drug used like magnesium sulfate also can have toxicity to them. That is another thing. Where to put IV cannula, very important. So routinely we will put in the upper limb, but avoid using in the lower limb. That is the suggestion that they have given. Next, lateral uterine displacement, very, very important. The most important thing, not in cardiac arrest, any pregnant patient you are achieving the BP, do the lateral uterine displacement. Lateral uterine displacement. Then regarding perimortem cesarean section. What is perimortem cesarean section? We have discussed. and which are the team members that is needed. So this is a pretty simple algorithm, but there are certain additional points that you have to be very specific in a maternal cardiac arrest that you have to remember, which are the A, B, C, D, F. You can have anesthesia complication, B is for bleeding, C is for cardiovascular complication, D is for any drugs that can cause cardiac arrest, and E is for embolism, G is the general factors, F is for fever, and H is for hypertension. So these are the things that you need to remember for a maternal cardiac arrest. So that concludes as all the algorithms, major algorithms. I have not done the opioid algorithm. Rest every algorithm we have covered. So we have to be very, very thorough with this algorithm. So that concludes our series of lectures on advanced cardiac life support algorithms. Okay. Thank you.